Good afternoon. My name is Jenny Hudson, and I'm the Manager of Communications here at the Christ Hospital Foundation, and I'm excited that you could join us today for our virtual education series, Insights and Conversation. Today's presentation will feature our high-risk cancer screening program, and we are proud to be joined by two of Christ Hospital's finest, Dr. Jennifer Manders and Bryanna Rivers. And in addition to our keynote speakers, we will also hear from one of our hospital leaders, Debbie Hayes, our current interim CEO, president and CEO, and also our director for precision medicine, Dr. Burns Blacksall, PhD. Finally, my colleague, Beth Nolman, will offer some final comments following the Q&A. Now, as a brief reminder, there will be a Q&A at the conclusion of our program. You can submit your questions to our physicians using the Q&A window. Additionally, if you need any assistance, you are welcome to use the chat feature and we'll do our best to respond. You can access both of those windows by selecting the icons at the bottom of the screen. And before we begin the formal presentation, I'd like to kick off this webinar with a special welcome from Debbie Hayes, our interim president and CEO for the Christ Hospital Health Network. Debbie has been a member of the Christ Hospital family for 33 years, might be 34, not sure when the anniversary is. She started here as a nurse's aide and she's done virtually everything in the hospital. So including, as I said, the interim chief operating, or excuse me, she is our chief operating officer, but she's also our interim CEO and president. So welcome, Debbie.
Thank you, Jenny. Good afternoon, everyone. Thank you so very much for joining us today. I'm very excited to have you all with us. It's our hope today that you're going to find value in this discussion as we learn together about how you can be more informed about your breast cancer risk and the important advances in genetic testing and how that can play such a huge role in assisting you to understand what your risk is. Today, as Jenny said, you're going to hear from three extraordinary leaders here at the Christ Hospital Health Network. First, Dr. Jennifer Manders. Dr. Manders is the president-elect of our medical staff and a surgical oncologist by training. On a personal note, Dr. Manders is a very dear friend, but most important to this conversation is that Dr. Manders is one of the most dynamic physician leaders I have met in my 33 years in healthcare. She has been in large part responsible for helping us to build what I believe to be the strongest breast cancer treatment program in this city. Also joining us today is Dr. Burns Blacksall. Dr. Blacksall is the director of our precision medicine program. He joined us here at the Christ Hospital several years ago with a long and distinguished career in clinical research and innovation related to the newest treatments in the field of cancer and other diseases. He has been the catalyst for working with our teams to build our precision medicine program and working with our physicians and spearheaded the evolution of our high-risk cancer screening program. And last but certainly not least, Bryanna Rivers, one of our fantastic genetic counselors who works in our high-risk cancer screening clinic and who I think you will be completely elated to meet. As a health network, our goal is to help you be more informed about your potential health risks, breast cancer being just one of them. And so today, I'm thrilled that these three leaders will share with you information about our high-risk cancer screening program and how in just a short amount of time, we've been able to help more than 10,000 women learn more about their hereditary cancer risks. If I could for just a minute. The Christ Hospital has been recognized by U.S. News and World Report as the #1 hospital in this region for 6 consecutive years, a top hospital recognized by Newsweek as one of the top hospitals in the country in 2021, and the most preferred hospital in Greater Cincinnati for 23 years. Now, why do I tell you those stories? It is not to be boastful, but it's really because of how we were founded. In 1889, more than 133 years ago, through a philanthropic gift made by James Gamble and many other civic leaders, is what helped us to create the Christ Hospital. And so today, we know that philanthropy helped to create us, it helped to create our strong foundation, and it continues to be vitally important all these years later. So today, we are going to pay tribute to those very generous civic leaders and continue on our mission to improve your health and the health of our community by providing you with leading edge treatment options. Thank you so much for joining us today. I hope you enjoy the presentation. Jenny?
Yep, I'm here. Sorry about that. I was just moving a box around. Thank you for that, Debbie. Thoughtful and great as always. At this time, I'm pleased to introduce to all of you Dr. Burns Blacksall, the Director of Precision. I just like to say his name. That's why I say it that way. Director of Precision Medicine at the Christ Hospital. Dr. Blacksall joined us from, as we said, Cincinnati Children's Hospital in 2019 and to start the Precision Medicine program here at Christ. So Burns, we're happy to have you, and I will turn the mic over to you.
Excellent. Thank you very much. And I will tell you, it is a real honor to be here at the Christ Hospital. It is really an amazing place to work and to develop relationships that will last a lifetime. And as Debbie Hayes mentioned, our goal here is to partner with our patients to become more proactive about their health care. And so what we're developing in our program of precision medicine are three main pillars of how we'll do this. We'll focus on one today, but I want to make sure you're aware of all three. The first that we will talk about today is proactive evaluation of hereditary disease risk. So there are two diseases for which we can evaluate, two main disease entities for which we can evaluate hereditary risk: cancer and cardiovascular disease. And so we'll talk today about cancer in particular. The second is a fancy word called pharmacogenomics. So pharmacomedicines, genomics, how genes impact the way medicines work. And that's a program that I would love to talk more about in the future. And the third is the underpinning of all of this is using artificial intelligence databases so that we can give you the best possible informed clinical decisions about your health. So on the following slide, I'll just walk you through one of the methods by which we are trying to proactively evaluate hereditary disease risk. And this is a program that we launched just over 6 months ago in our mammography clinics. So for patients coming to get their mammogram, 5 days before their visit, these patients receive a text message on their phone or an email to their email, inquiring whether or not they would like to fill out a chatbot. And one of the beauties of this is that this is an evaluation that can be done at home. So many times you may have gone to the physician, they ask you 100 questions in the office, you don't remember all the answers. This is something that can be done at home, and you can take a pause and call up Uncle Fred or Aunt Sally and ask what, did they have a cancer diagnosis, what age, what was it, et cetera, all the details. And in the course of 3 to 5 minutes, patients fill out this chatbot and evaluate their hereditary disease risk. And it calculates a score that determines whether or not they meet National Comprehensive Cancer Network guidelines to do a hereditary genetic evaluation of their cancer risk. In the event that patients are not able to fill this out before they come in the next portion of this slide, you'll see that we also offer patients a tablet in the clinics, in all of our clinics, or we can also push this notification to their device if they have it. So they can fill this out to, again, evaluate their hereditary disease risk. And this is what Debbie was mentioning. In just over 6 months, not quite 7 months, nearly 12,000 patients have filled out this chatbot. And of those patients, over 2,800, nearly 3,000, have met National Comprehensive Cancer Network criteria for hereditary cancer testing, which I think is just absolutely remarkable because we're only targeting a portion of our patient population that are coming in for mammograms. Plenty of women of age don't come for their mammograms. And there are other patients across our whole network that could benefit from this. So we're really excited about this. And as was mentioned, we developed a hereditary cancer screening clinic, a high-risk cancer screening clinic. For patients who meet these guidelines, they will come to see a genetic counselor and discuss the benefits of genetic testing. So you'll hear from Bryanna Rivers about that. And then also you'll hear from Dr. Jennifer Manders and the advanced practice providers who in the clinic will also meet with patients who are at elevated lifetime risk for cancer and qualify based on this criteria for scores where they may want to consider referrals for prophylactic chemotherapy or other things like that. So I will leave those discussions to Dr. Manders and Bryanna. And again, just really want to thank you for joining us today. We really look forward to your questions at the end and would be happy to have further discussions outside of this if you so choose. So I will now turn it back over to Jenny and then Dr. Manders and Bryanna Rivers.
Thanks, Burns. We really appreciate it. It's really encouraging to see all the great work underway in the precision medicine space. And I'm excited as to how things are going to continue to evolve for this program. So in just a minute here, we'll be turning things over to two presenters today, Dr. Jennifer Manders and Bryanna Rivers. But I do want to mention that Burns, Dr. Blackswell will be staying on the call and is happy to answer any questions during the Q&A later in the program. So now I'm excited to turn things over to our two keynote speakers for what promises to be an informative and engaging presentation. I'm pleased to introduce Bryanna Rivers, a genetic counselor in the high-risk cancer screening clinic, and Dr. Jennifer Manders, surgical oncologist, cancer wizard, and president-elect of the Christ Hospital medical staff. Bryanna is going to go first and will be talking about the powerful role that genetic counseling and testing can have with detecting hereditary cancers. Bryanna received her bachelor's degree in cell biology and molecular genetics from the University of Maryland and a master's degree in medical genetics from the University of Cincinnati. She grew up outside of Washington, D.C. and loves to travel, going to the theater and exploring museums. Bryanna first became interested in genetic counseling during her undergraduate studies and then went to work as a genetic counselor assistant for a program in Baltimore that specializes in inherited heart conditions. And during her graduate training, she was afforded the opportunity to expand upon her interests. And at the Christ Hospital, she now works specializing in both cardiovascular and cancer genetics. Bryanna also sees patients for the genetic counseling portion of the high-risk cancer screening clinic at our Mount Auburn campus, along with an advanced practice provider. And she works with patients to help them understand the inherited risk factors for different types of cancers. So Bryanna, tell us just a little bit about why genetics? How did that come to be your interest in your career? I can't imagine how much it's changed just since the time you graduated.
Sure. So when I was an undergrad, I knew I was interested in biology in general, but was really fascinated by my genetics classes. And so I spent a lot of time trying to figure out what to do with a genetics degree, just because genetic counseling isn't something that is often talked about in colleges. They often talk about med school or working in a laboratory, but they don't often talk about genetic counseling. So I found it actually by way of just research on my own and fell in love with the idea of genetic counseling and thought it was super cool. And as you mentioned earlier in my intro, which thank you so much for that, I did right after undergrad, I worked as a genetic counselor assistant for a genetic counseling program or cardiovascular genetic program. And so that really just solidified my passion for genetics. I thought it was I loved seeing how the genetic counselors worked with the patients to help them understand their genetic risk factors and help them to understand with a genetic diagnosis and explain it to their families as well. So I ended up going to grad school for it because I just thought it was super cool and very interesting. And here I am now.
Well, that's great. Thanks again for joining us. And I will turn things over to you.
Thank you. Go ahead and hit that next slide. Thank you. So I just wanted to start with a brief overview of what genetic counseling is, because as I mentioned, it isn't something that everyone is fully aware of. Even a lot of people that I graduated with didn't find out until much later after they graduated college or sometime late in college. But basically, it is a process of guiding and supporting patients who are seeking information about inherited diseases. So whether that be cardiovascular disease, whether it be cancer, inherited cancer syndromes, and we're going to focus today primarily on inherited cancer syndromes, but genetic counselors work in many different areas of medicine. You know, we have prenatal genetic counselors, pediatric genetic counselors, and we have advanced training in both medical genetics and counseling because we deal with some pretty complicated social implications of dealing with the genetic condition, and also have to kind of break it down for patients to explain to them, you know, what exactly is causing this increased risk? How do we mitigate that risk? And we go over that step by step with patients. And so our role is we go over the pre-test education and counseling. We talk about the different testing options, help patients make that decision based off of their personalities, like if they're, you know, a very anxious person versus someone who just really wants to know everything. And then we'll go over those results with them when they come back. And that's what goes into the post-test counseling. It's counseling them on those results and letting their providers know, and making any referrals if we have to. So we review with them, like the patients, any cancer screening that they may have had up until the point of our appointment. So if they have a family history of cancer and they may not have had any screenings themselves, we'll make note of that. Or if they've already had screenings leading up to it, if it's normal screening in the high-risk cancer screening clinic, we'll make note of that as well. Or if we do see patients who have had a personal history of breast cancer or other cancers, we'll just really get into detail about the types of screenings they've had and what those results were. We also strongly focus on a family history. So we go, you know, we ask about aunts, uncles, first cousins, grandparents, children. And so we really get into the details of the family history and even the details of, you know, whether somebody is a half sibling versus a full sibling because of the degree of relatedness. And it is important to know that information when you're assessing a patient's risk and where the cancers are kind of showing up in the family. And we also go over the types and the ages of diagnoses of some of the cancers in the family. Because especially, you know, there's a difference if, you know, grandma had breast cancer at 83 versus, you know, at 45 or at 37, because we definitely are more suspicious if the cancer diagnoses are younger. And so we just go over the types of cancers, in those ages of diagnoses. After we go over both personal and family history, we take all of that into account to discuss what the appropriate genetic testing options will be. So there are oftentimes different panel options. And basically what a panel is looking at multiple genes as opposed to just one. Some panels focus just on breast cancer risk. Some focused on breast cancer risk, colon cancer risk, stomach cancer. So it really just depends on what are the cancers that are showing up in your family. And if we just do a breast cancer panel, are we going to be missing those risks for, you know, all of the colon cancer that's in the family, and kind of go over stuff like that to determine what the best panel would be for the patient. And we also talk about the possible results, you know, positive, negative, variant of uncertain significance, and the implications of those and what comes next. In discussing this, we do go over the pros and the cons of testing, you know, and we'll get more into detail about the pros and cons of testing later. But it is something that we go over because ultimately our role as genetic counselors is not to force patients to have genetic testing. We do understand it's a very personal decision to have genetic testing because it is your genetic information. But we explain, you know, how it can be helpful, what the pros and the cons are, you know, how it impacts screening and management and testing other family members. And then ultimately it's the patient's decision whether or not they want to proceed with testing. And so I touched on a little bit, you know, the types of results, positive, negative, and variant of uncertain significance. But the process of genetic testing itself is actually, we are honestly looking at to see if there's any spelling errors, or we're looking at the genes that we decided upon or the panel that we decided upon to see if there's any genetic changes or mutations that may put a patient at an increased risk for certain types of cancer. And then we go over what the possible results may be. And of course, when those results come back, review them with the patient. So when a patient gets a positive result, and here going into like the pros of genetic testing, a positive result can be very informative to the care providers. It can be very important to the patient as well. but it can help determine what are the specific cancer risks for the patient. So, even when they're referred for a family history of breast cancer, there are some genes that we see, both an increased risk for breast cancer and colon cancer, or increased risk for breast cancer and thyroid cancer. And so we want to make sure that we are screening the patient appropriately, because if there's this increased risk also for thyroid cancer, maybe they weren't getting thyroid ultrasounds, or maybe they weren't getting other screenings, that now having this positive result, it is more informative in terms of what other screening may the patient need. Or with increased risk for breast cancer, if there's any advanced imaging that a patient may need, as opposed to just an annual mammogram. It can be helpful in terms of earlier screening, starting those mammograms earlier than age 40. So it can also, for patients who have had a diagnosis of cancer, they may make the decision about doing a double mastectomy, or diagnosis of breast cancer. They may do a double mastectomy if they have a positive result, or someone who has a family history but tested positive may do a prophylactic mastectomy. So there's lots of different decisions that can go into a positive results for a patient's personal health. But then also there are decisions that can be made about testing other family members. And so that's the reason we get into that family history, get the structure of the family history, and say, I know, you have 3 children, each of them are at a 50% chance of having the same exact genetic change, and then offer testing for those children, and offer testing for, for family members, your brothers, sisters, parents, if they're around. And so it does help kind of guide who else in the family is at risk and who else may benefit from testing. And it can honestly be helpful in terms of finding an answer, sometimes, especially with young ages of diagnoses. Why did someone get breast cancer at 33? A positive result can provide an answer for that patient for something that just seemed very random and out of the blue. And then a negative result can also be very helpful as well. So I know we talked a little bit about surgical decision-making. Having a negative result can also impact that decision. Maybe the patient won't choose to do a double mastectomy, or maybe it'll give them some peace of mind knowing that, at least with the testing that we did, there wasn't anything that we identified that puts them at an increased risk over general population. And so maybe their breast cancer was less likely to be related to an inherited cancer syndrome, or if they don't have a personal history of cancer themselves, even if there's something going on in their family, a negative result, or they get a negative result, it's possible that there is something in their family that they did not inherit. So we would still tell patients that, hey, it's possible that you're negative because there's something in your family you didn't inherit, but your cousin might be a good person to do genetic testing if he or she has not had testing because of this cancer at this age. So some of the cons of genetic testing, I know I talked about, we make these decisions on panel sizes based off of patients' personalities. We have a lot of patients who say, I do not want to do a big panel because I don't want to open up that can of worms, or it would make me very anxious to go digging for something that we don't see in my family history. And so they may just want to know, I just want to know, do I have a risk for this, these small subset of genes? And that's all I want to know. I don't want to know about any of the other ones. Or a variant of uncertain significance. I mentioned that a couple of times, and that basically just means there is a genetic change that right now the lab doesn't have enough information to determine whether or not it's disease causing. And so with these VUSs, we can't make any management decisions. We know it's there, but we can't do anything about it. And some patients do feel very anxious about that. And then some patients may actually stress out about a positive result. And sometimes we have had patients decide they just don't want to know because they know themselves and they know that it would cause them to stress out and that it would be all they think about. And then we've also had patients who, get very emotional if they've got tested positive and then their child's tested positive. They get very emotional with, guilt that they've passed something on. Even though it's not, they can't choose what genes that they pass on, but there still can be complicated emotions surrounding that. And we also talk about things like insurance discrimination. So there are some laws in place that offer protections for health insurance, but positive result for genetic testing can theoretically make it more difficult to get life insurance. So we go over all of the nitty-gritty details about life insurance as well. And also, it's a different discussion. We're talking to someone who's had a diagnosis of cancer versus someone who has not had a diagnosis of cancer. And lastly, we might actually find out more information about something we weren't expecting, something that comes back positive that the family history is not super suggestive of. And so that is something that we see, not all the time, but on rare occasion, we do get a result that we weren't necessarily expecting based off of personal and family history.
All right, Bryanna, that is terrific. Thank you so much for such a great presentation.
Thank you.
Please forgive me while here we go. We actually have gotten a few questions already from our audience. So those people who are listening, we're going to get to your questions as we get to the Q&A later in the program. So now I'm very excited to introduce Dr. Jennifer Manders, who will continue today's presentation. She is recognized as a top doctor by Cincinnati Magazine and also by all of her patients. She is a board certified general surgeon and a member of the American College of Surgeons and the American Society of Breast Surgeons. Dr. Manders earned her medical degree from the Chicago Medical School and completed her general surgery residency at Rush University Medical Center and her breast surgery fellowship at Northwestern University Feinberg School of Medicine. In addition to her clinical responsibilities, she is now the president-elect of the Christ Hospital Medical Staff. So Dr. Manders, Q&A, why did you go into breast cancer surgery or surgical oncology? I guess we can put it that way.
So first, let me say thank you for the introduction, and I'm really happy to be here. And I can't wait to get into the nitty-gritty of our talk, but how did I decide to go into breast cancer surgery? So if you roll the clock back about 20 years or so, and I was a resident in surgery, I was doing a thoracic surgery rotation. So that was mostly lung cancer patients. And I loved the way the team worked together to take care of these patients. And this was at Cook County Hospital. So it was like very underserved, poor patients who really didn't have a lot of resources to be able to even get themselves to the hospital. So it was a team approach. It was multidisciplinary. The surgeons worked with the radiation oncologists and the medical oncologists, and you had pathologists in the room and radiologists all looking at each case together and making decisions about treatment. And it really felt collaborative, and I just loved that. So the idea of surgical oncology kind of arose then. And then the decision around breast was really based on a couple of things. One, that my patients are mostly women who it's just so empowering to be able to take care of women and watch them go through the journey with them and really see them transform in lots of ways during the treatment and then afterwards as survivors, but also because and I just alluded to it, the fact that I get to have these long-term relationships with people, I really think that's wonderful and very, very satisfying just as a human being. And for me, being able to fix somebody's hernia and saying goodbye to them was nice, but it wasn't what I wanted as a career. So here I am. So thank you so much for having me today. And Jenny, thank you for hosting. It's a joy to be with you.
Take it away.
All right, so thanks, Bryanna, for talking about the genetic component of risk assessment. So there's also a clinical side of risk assessment, which is really based somewhat on genetic testing, which we'll talk about in a few minutes, but really a lot of clinical factors as well. And how we use that information to counsel women is interesting and variable and from patient to patient and changes over time. And so what I wanted to show you was an example of, this is all de-identified, but a patient-specific risk assessment. So as Jenny mentioned, I'm part of the American Society of Breast Surgeons, which is a membership that really focuses on quality of care. And we have our own database that is shared amongst all of the members, and you can follow your own patients. It's also a way to keep track of all of your patients' individual data. And so for our high-risk patients, We have access to multiple risk assessment models that we can use in order to calculate somebody's likelihood of carrying a gene mutation, like in this case, which you can see. And then as we get through the next couple of slides, it'll be about their likelihood of developing breast or ovarian cancer. And so the risk, as you may know, BRCA1 and BRCA2 were the two original genes that were identified about 20 or 30 years ago that were first found to be associated with an increased risk for breast cancer and ovarian cancer. But since then, there have been many, many genes identified, and some we know to have a significant risk, and some are maybe more moderately associated with breast cancer risk. But some of these risk models were developed 20 years ago or so. And so in those days, really, we only had access commercially to BRCA1 and 2 for testing. So you see 4 models in front of you: the BRCA Pro model, Tyrer-Cuzick, version 7 and version 8, and then the Myriad models. And all of these use different pieces of information to determine what's the likelihood that this patient sitting in front of you carries a gene mutation. And it looks at multiple generations within the family, helps you create a family tree with all of the information that Bryanna was talking about, and then calculates the likelihood of a gene mutation. And so there are different recommendations. Specifically if the risk for carrying a gene mutation is above 10%, that's an indication for genetic counseling. But nowadays, anybody with an elevated risk above 5% is usually referred, and anybody with a new diagnosis of breast cancer should be given the opportunity for genetic counseling. But I digress, because right now we're not talking about breast cancer patients, we're talking about high-risk patients. So this is a patient of mine in whom we've talked about her together. She and I talked about her risk, and then we input all of her data, and we came up with, these are her numbers. So what you can see ahead of you now is the risk for breast cancer and the risk for ovarian cancer over the course of her lifetime. And there's another couple models in here called the Gale and the Klaus model. And these all give you the likelihood in the next 5 years that a patient has breast cancer, and then the likelihood over the course of her lifetime. And they all use different risk factors. And so you might say, well, what do I do? Do I like average all of these out? Is it a range between 2.2 or 1.5 to 10.1 in her 5-year risk? No, what we say is that different risk models use different characteristics. And so the Gale model may take into account somebody who has atypia and look only at her first degree relatives, like her mom or her sister or her daughter with breast cancer. The Tyrer-Cuzick model takes into account additional family members who may have breast or ovarian cancer, takes into account the patient's body mass index, takes into account the use of hormone replacement therapy, and also the density of her mammogram. So there's so much information that these different models use that they come up with different numbers. They're all validated models. It's kind of like 2 things that can lead to heart disease are smoking and high blood pressure. And just because they're different models doesn't mean that one rules the other one out. These can coexist at the same time. So these models all are validated. In this patient's situation, her Gale model number of 5.1 is significant, but like as high as 10.1 is scary high, as I like to think, because the average 64-year-old woman who doesn't have any risk factors for breast cancer, just her age, has a 5-year risk of 1.67%. So almost every single model that we have here has demonstrated to us that this patient's likelihood of breast cancer in the next 5 years is really high. And then we look at the lifetime risk threshold of being 20% or greater. And so you can see that Klaus puts her down to 4.4, and the Tyrer-Cuzick model has her in the 30s. So we use this as an indication for how closely should we be monitoring this patient. Should she be getting additional imaging aside from just annual mammography? Would MRI be helpful in this case? And then do we consider doing prophylactic surgery at some point in her life? We do have medications that we use to help prevent breast cancer, and those are usually given for 5 years. And that's what we use the 5-year risk to help make the discussion about, should this woman consider going on something like tamoxifen or Arimidex or exemestane, which are all breast cancer drugs, but have been proven to help reduce the risk for breast cancer. So it's really then a discussion of, the side effects versus the benefits, and where does her level of anxiety sit, knowing these numbers. So again, just like genetic testing, not everybody wants to know this information. Not everybody wants to see these numbers, because this can be very anxiety provoking for people to know that this is existing in the background. And so, you know, it's really worth a conversation ahead of time. Like, is this something you want to know? Not everybody wants to know. And I have plenty of people tell me, yeah, I'd rather not go down this road with you. And so then we just say, okay, well, let's talk about what you're willing to do. We can also predict the ovarian cancer risk over the next 5 years in lifetime. And it's only the BRCA-Pro model that is able to do that for us, because the BRCA-Pro model takes into consideration the likelihood of carrying a gene mutation. And so we know breast cancer and ovarian cancer is related via the BRCA1 and 2 genes. So family history of ovarian cancer plays into that calculation as well. And then we're also able to, like in this case, it says tamoxifen benefit risk index. We can talk about not just tamoxifen, but other medications that may help reduce risk, and what are the side effects, and is that of interest to the patient. So next slide, please. So just like we do for genetic counseling, we take family history into consideration, and just like we want to know what malignancies they had in the age that they were diagnosed at. It's also important to figure out if this is coming from the maternal line or the paternal line, because if we see it looks like multiple family members on one side of the family, multiple generations, that's more suspicious of an underlying gene mutation. And in this case, the patient had a cousin on her mom's side who tested positive for an ATM mutation, which is a gene that's associated with breast cancer. The patient herself tested negative, and all of the other people in the family either tested negative or haven't undergone testing. So sometimes knowing that there's a gene mutation can help figure out the individual's risk, but sometimes it doesn't tell the whole story. And then we'll go to the next slide. So these, again, are some of the risk factors that we take into consideration. And like we said, height and weight helps us calculate the BMI. The breast density is measured on different scales, but generally speaking, the BI-RADS-C and the BI-RADS-D classification means that you either have what's called heterogeneously dense breasts or extremely dense breasts, which makes it harder to identify cancers, but also independently is a risk factor for developing breast cancer. Whether or not a woman is of Ashkenazi Jewish inheritance is important, because there tend to be higher incidences of gene mutations in this group of people. And then when she gave birth to her first baby after the age of 30 is a relative doubling of her risk. And so again, I say relative because if your risk is low to begin with and you have your first baby at 31, then you're doubling a low number and it's still low. But if this is one of many risk factors, it can be a significant increase. We look at her menstrual history. We look at the use of hormone replacement therapy, and then any biopsies that she's had done. And the findings on certain biopsies increase the risk significantly. So atypical ductal hyperplasia is a finding that is diagnosed by pathology. And so this is not just in the miscellaneous diagnosis of fibrocystic changes that maybe your doctor tells you have, but this actually is a precursor to breast cancer. And so this is a picture of a family tree that many of you may have seen before, but the patient with the arrow is actually our patient that we're talking about. She's the one who was diagnosed with having atypia at age 64. And then it shows the rest of her family's history as well. So this is just a demonstration of some of the detail that we get into and how we utilize this information in order to push the conversation forward and come up with a very customized plan for each individual patient as to what works for her. And every response that one could hear, I hear, and there are no wrong responses. It's just what's right for the individual. There are situations where people come in and they don't have a high risk, yet they still want prophylactic mastectomies because of anxiety. And so there are plenty of times that we have to sort of talk people down. But in general, when a woman's risk is high, all options are on the table. So with that, I'd like to turn it back over to Jenny, and then we can open it up to Q&A.
So I'm actually going to go over a couple of case examples first. So a couple of ladies who actually came through our high-risk cancer screening clinic. I did abbreviate it throughout the rest, or through my slides, as HRCSC. And so we had a 45-year-old female who was referred to our high-risk clinic due to a family history of breast cancer. So on her mom's side of the family, quite a bit of people, including her mother, 2 of her aunts, and her maternal grandmother had breast cancer. But there was also some lung cancer, kidney cancer, and colon cancer on her mom's side of the family. On dad's side of the family, we see prostate cancer in her father and colon cancer in her paternal uncle. So we definitely figured there was some inherited risk factor going on in the family with all the breast cancers, and some of the other cancers as well can be suspicious for actually a different type of cancer syndrome. And so she is considered high risk for hereditary breast and ovarian cancer syndrome, given the multiple cancer diagnoses on her mom's side of the family. So we do genetic testing. She actually chose the 84 gene panel, so the biggest one that the lab we use offers. And she actually tested positive for a gene mutation in a gene FLCN, so it's the falcon gene, associated with a condition called Birt-Hogg-Dubé. So I know I touched on earlier, sometimes we can find out information that we weren't necessarily expecting. With her family history, we felt if anything came back positive, it would be related to breast cancer, but Birt-Hogg-Dubé is not at all associated with an increased risk for breast cancer. It's actually associated with multiple, we can see a lot of benign tumor growth, simple cyst formation, but we can see them in the lungs, kidneys. We can also see them like benign tumor formations in different parts of the body. Her positive results actually did change her clinical management. So now going through the genetic testing process, we found out information that maybe we weren't expecting, but now she's getting screening and management that she would not have had she not gone through with the testing. And so she was referred to hematology and oncology. So she's in touch with an oncologist. She was referred to pulmonology due to the risk for those lung cysts, and also urology because of the kidney cysts. And so they actually did do follow-up imaging in an MRI. They identified a simple cyst on her kidney. So they were able to do some additional screening based off of the results of her genetic testing that she had through our cancer screening clinic. And then I only have one more patient here that I wanted to present. So she's a 53-year-old female, and she was referred to the high-risk clinic due to her family history of breast cancer. So mother had breast cancer at 71 and again at 86. Her sister was diagnosed with breast cancer at 29, which is very, very young, and passed away at age 35, and a maternal first cousin who was also diagnosed with breast cancer at 30. So she actually did not see a genetic counselor through the high-risk clinic because she did previously have genetic testing a few years prior. And the testing she had wasn't the largest available panel, but it was still pretty comprehensive. It at least covered, many of the high-risk breast cancer genes. And so she decided that she did not want genetic counseling, which is fine. And then, so she was still considered high risk. So it was important for her to at least meet with one of our advanced practice providers, so they're APPs. And so she was followed by one of our APPs in the clinic who recommended a mammogram and a breast MRI as part of her high-risk breast cancer screening plan, given her family history, even though she had negative genetic testing results. So as I mentioned before, there were a couple of reasons for a negative result, even with family history. And sometimes, even if we aren't able to identify a genetic cause, some patients may still be high risk based off of their family history. And as Dr. Manders mentioned earlier, knowing that someone else in the family has a positive result and then your patient testing negative, that can be helpful. I mean, like, okay, we know our patient was tested for that. Our patient does not have that. But if no one else in the family has had genetic testing and our patient tested negative, is it because there is no inherited risk factor in the family, or is it because we just didn't look at all the appropriate genes, or there were lots of different reasons? So the patient actually was referred for her mammogram a few weeks later, and there were some benign findings that were identified. So there wasn't anything on the mammogram that they were super suspicious of. And so they said, okay, come back in a year for a mammogram. So 4 months afterwards, she actually did have her breast MRI as part of her high-risk screening plan. And there were some abnormal changes that were identified on the MRI that weren't picked up on mammogram. And so they did a biopsy, and the biopsy did identify that she had early stage breast cancer of her right breast. And so this patient, obviously knew she was high risk based off of her family history, but may not have gotten a breast MRI had she not, gone through the high risk clinic, or it may not have been recommended if she hadn't gone through those risk numbers that Dr. Manders talked about, of just kind of knowing your numbers, knowing what your specific risks are based on those models. And she did have negative genetic testing, but it was done several years ago. And again, like maybe there just may have been more genes that the patient could have benefited from having evaluated, but she wasn't interested in additional testing, but that doesn't take away her risk based off of her family history. So she was able to then go on to have earlier detection, better chances of treatment, and continued screening. Thank you, everyone, for your time.
Oh, thanks, Bryanna. We really appreciate it. And thanks, Dr. Manders. As always, a fantastic presentation. We are getting lots of questions.
Good.
So here we go. Here's the first one. Bryanna, as a genetic counselor, how do you approach a case where someone is adopted and they don't know the medical history of their parents other than knowing the parent or parents' cause of death?
Yeah. So we actually see several patients who are adopted, and we often recommend our patients to go for a larger panel. I know we talked about, a little bit of different panel sizes, but there could be, lots of thyroid cancer in their family, lots of colon cancer in their family that you just aren't aware of. And so oftentimes people come in concerned about breast cancer risk, but I do think it's important to, think a little bit big picture when you really don't know the family history. And so it just doesn't preclude anyone from getting genetic testing. And so we definitely say, okay, well, don't know family history, but we can still go ahead and offer testing.
Mm-hmm. Okay. Let's see, here's another one. My 21-year-old granddaughter has had 2 breast cysts. One is new and one is increased in size from 2 years ago. There's no family history of breast cancer, but her mother has also had breast cysts. Should she be genetically tested? And is there a value to having the cysts removed? Is there any correlation between cystic breasts and genetics for breast cancer?
So I'll touch on one part of that, the genetics piece, and then Dr. Manders, I'll let you get into the risk for breast cancer with those cysts. We can see, cystic breast running in families, like we can see multiple people in the family with cystic breast, but from a genetic standpoint, we wouldn't offer genetic testing for that alone. And I'll kind of let Dr. Manders get into a little bit as to why, but we typically don't see inherited risk factors for cancer with multiple breast cysts in the family.
So I agree totally. So breast cysts are completely benign, and there have been studies looking at the affiliation of cysts and subsequent cancer, or the chance of missing a cancer within the cyst. These are really, really rare situations and are probably not actual causation, but just more correlation. I would say if the cysts have any suspicious features to them, it's worth investigating. And that usually is done with an ultrasound guided aspiration, fine needle aspiration of the fluid, which can then be sent for cytology. So they can look at the fluid under the microscope and see if there are any actual abnormal cells in them. But based on imaging characteristics on an ultrasound, you can usually tell what's a simple, completely benign cyst and what's not. As far as removing these cysts, again, it would probably be based on whether they were simple or complex, if they recurred after you've aspirated the fluid out of them, if they were symptomatic. So there's no rule that says cysts need to come out, and many women live their lives with many cysts. Sometimes these are exacerbated by caffeine consumption, smoking, all sorts of other risk factors, and potentially even diet. So it's kind of like, I tell women, it's kind of like trying to take the holes out of Swiss cheese, which is a very, very difficult thing to do. Be reassured that benign cysts are just what they're called, benign. And while they are a pain to have to deal with, they are not a high-risk situation.
Great. Here's the next one. Do you have a hereditary clinic with multiple specialty providers for positive genetic mutation patients?
It's an interesting question. I'll happily take that one. So right now we're largely doing hereditary disease evaluation for cardiovascular and cancer. And within the cancer space, we do have our high-risk cancer screening clinic where our APPs, and as we expand that clinic, we'll be able to deal with and or refer to any medical oncologist, surgical oncologist for any type of cancer risk. For cardiovascular disease, Bryanna is our expert in that space. And we have an amazing heart and vascular team. And so we'll make sure that the patient gets to the right disease specialist if there's a particular susceptibility that's detected with genetic testing. I hope I answered your question. And if I didn't, please feel free to reach out and we'll try to address that further. Jen, Dr. Manders, do you have anything else you wanted to add?
Yeah, I was just going to suggest that, you know, many of us who do genetic, well, I would say we're the surgeons who deal with genetic mutations on a regular basis have a level of comfort counseling patients about what the risks associated with those mutations might be. And so there are plenty of people who carry mutations that increase their risk for breast and say thyroid cancer. And in many cases, I'm the one who's monitoring their thyroid with every 3-year ultrasound or, you know, ordering biopsies or things like that. So depending on how one identifies that they have a gene mutation, who they're already connected with, that can help them get into the system of who they need to see. And so for people who are at high risk for, say, pancreatic cancer, often I will have a GI doctor who's involved in their annual or every other year evaluation. So great question. And it would be wonderful to have so many people plugged in that we can just like float everybody in the direction they need to be. But I think that this is a growing field and not everybody feels quite as comfortable counseling the patients about what it means to have these gene mutations. So we really heavily rely on national guidelines.
What is your threshold to differentiate a patient to be high risk? Is it 10% or?
It's a good question. So lifetime risk above 20% is considered high. And that's when we start talking about things like MRI. And depending on how high, like if you have a BRCA gene mutation, your lifetime risk for breast cancer could be as high as 87% in some literature. And so in that situation, we would be very, very reassuredly, we would be having a conversation about surgery for prevention. And not everybody chooses that. But that is sort of one of the things that we look at in terms of how we manage the risk. And then for 5-year risk assessment, anything above 1.67% is considered high. Good questions.
Yeah, and I would just add to that, there are national guidelines that not only dictate who should get hereditary cancer testing, but also insurance companies have guidelines for who qualifies for the advanced screening, et cetera. So, for example, the number that Dr. Manders suggested of 20% usually qualifies patients for all the enhanced screening that they'll go through. So we really, as was mentioned, we try to follow those national guidelines to define patients at risk.
And I know some of those risk factors are located on our website under the high risk cancer screening page. So go to the website if you want to check out some of those. www.thechristhospital.com. The next question, why is breast density a high risk factor?
Great question. So it used to be thought that it was because things would just hide within the density that it was difficult to find cancers. But what we know is that the density is actually an indication of how quickly cells are growing and proliferating. And while those cell changes are happening, the faster cells are growing, the higher the risk of developing some atypical changes within the cells. And so it's really like a surrogate for what's happening at the cellular level, the amount of density within the breast tissue.
How do you know who is considered high risk? Does the mammogram itself show a patient to be a possible high risk?
So the mammogram may show us breast density, but it's really a combination of imaging, clinical factors, and family history that help us determine overall, you know, should somebody be evaluated for their risk. A lot of times that evaluation is initially done by the patient's primary care doctor or their gynecologist. And so it's really important that we have developed relationships with primary care and gynecology in order to help them understand and be able to recognize patients who could be at risk and refer them appropriately.
Okay. Patients qualify for genetic testing. Do those patients get testing results before they go into the high-risk program?
Bryanna, you want to take that?
Sure. I mean, some patients have had genetic testing prior to coming in. Actually, we will see them in clinic, in the high-risk clinic based off of this positive result, because a positive result alone puts them at high risk. But the way our clinic is currently structured is they'll come in, they'll see myself or my colleague Jana for the genetic counseling piece. We'll talk about the genetic counseling portion of it and the genetic testing. And then they'll go and see one of the advanced practice providers, and they'll do the physical exam and go over those risk models that Dr. Manders went over earlier. And so I communicate with the advanced practice provider. You know, we talked about doing this panel. Those results come back in about 2 to 3 weeks. And so what happens is after I call the results out to the patient and let their referring provider know what those results are, I will then also send those results along to the advanced practice provider that I work with, so that she's in the loop, in order to make sure that now knowing that they have a positive result, you know, after it's been a few weeks since we've seen them, now knowing they have a positive result, it may change what their screening and management plan would be if they were first going based off of family history. It may change based off of a positive result.
Okay. What if a patient is too young to start mammograms, but is considered high risk? How does that handle?
Great question.
Come right on in.
So it happens all the time, because what happens is that something called early penetration, which is each generation that carries a mutation, you tend to see the cancer develop earlier in the next generation. And so I have patients who are teenagers whose parents had breast cancer in their 20s, or you have people in their 20s who have parents with breast cancer in their 30s. So what do you do in these situations? Because doing a mammogram on a 19-year-old is not a great idea. Why? Number one, it's going to be very dense and very difficult to interpret, even with 3D imaging that we have now with mammography. But also, these breasts are probably still developing, and then you're going to irradiate them annually with mammogram. And so we avoid the use of any imaging that that delivers ionizing radiation at such a young age. We usually start mammography at around 30 is when we suggest it. Sometimes there are other reasons to consider it between 25 and 30 in certain situations like BRCA gene mutations. But in those cases where they're young, I'll usually do a breast MRI. We time it specifically with their menstrual cycle so that it's between days 7 and 14 of their cycle, and their estrogen levels are low, and so that not everything picks up the contrast. And then we just monitor them very carefully with twice-a-year examination. We used to have a screening program using ultrasound as well for women who had dense tissue. That has gone to the wayside and has been replaced now with a screening MRI for people who have dense tissue but are not at high risk. But if you feel something on examination, we can always do an ultrasound. It doesn't have to be just part of your annual imaging. So.
And I'll just tag on to that very quickly, just to clarify for everyone once again that in the event that a patient is discovered to have an actionable mutation that puts them at higher risk, every one of their blood relatives can be tested for that mutation for free for up to 150 days. So the whole goal of the program is to really partner with you and your families to evaluate hereditary disease risk, so that, for example, these patients that Dr. Manders is speaking of, whose parents had cancer and they're at risk, we can test all of them to evaluate risk and be more proactive with health.
Great, thanks, Burns. We had a question come in earlier that's actually kind of specific to what you're just talking about dense breast tissue and the necessity of an MRI. The woman who asked this says she knows it's recommended that every year she should get an MRI and has heard that insurance should pay for it. Unfortunately, this is not the case for her employer coverage. She wonders if the expense would keep many people from getting these tests done. And as a follow-up, if there are resources available to help patients cover the cost of a diagnostic mammogram and an MRI if insurance companies won't cover the cost.
So I feel like somebody from the Christ Hospital must have planted this question because it's such a great question.
We didn't, I swear. Scout's
so
honor.
Good. So yes, the answer is yes. The financial implication of ordering these tests has a role and plays a huge impact and is a burden for many, many people. And unfortunately, it sometimes precludes people from proceeding with the testing, and that is heartbreaking. We do have different sources of funding available. We have some generous donations from patients who help us support patients for imaging. There's something called the BCCP, which is the Breast and Cervical Cancer Project, which helps underserved patients who are at or below the poverty line, or even underinsured patients, undergo their imaging if they meet certain criteria for high risk. So, and then there's all kinds of financial assistance plans through the Christ Hospital specifically. So it breaks my heart when I hear that people have to make the decision to not get imaging because of finances, and I will go to the ends of the earth to do anything to help you. So please, if that is a concern of yours, don't let that stop you from coming and getting an evaluation, and let us help you figure out how to get what you need.
Yeah, and I'll just add on to that, as we developed the high-risk cancer screening clinic, we've received 2 generous philanthropic donations so far to help offset the cost of that initial visit to the high-risk cancer screening clinic for free for any patients who meet financial need criteria. So we really try hard to help you get across the line for anyone who has financial need, because again, it's heartbreaking to see people not get the care that they deserve, particularly based on their high risk.
Agreed. And that's another benefit of philanthropy, just to throw that in there. Here's another question. We have 2 more questions that have come in. If I am told I need future monitoring, I am 32 and need to start getting mammograms and start in your high-risk program at age 35, does Christ Hospital reach back out to me in 3 years, or do I have to remember to do that myself?
So that's a great question, because you're under the age of the annual imaging. That's our normal annual reminder. So when you enter into our system, once you hit the age of 40, there's an automatic pop-up that reminds us about annual imaging. But before that, it's not built into the system. And so this is why it's important to be connected, I think, to a high-risk program who can reach out to you. So that's a good question for Bryanna. Do we have any tickler to help remind us to reach out to somebody in 3 years? In our case, in our office, we do imaging starting at 35, but I would see you once a year prior to their age 35. So you're still a patient, you're still in the clinic. And so you don't have to be reminded on your own. Same thing for you, Bryanna?
I mean, I know that we've been working on, like, Burns, I don't know if you want to talk about like the BPA that we've been, I'll let you take that away.
Sure. So, any patient who is at high risk, I sincerely hope will go to the high risk cancer screening clinic, and you'll come up with an entire care plan with the APP. And then if you're seeking referrals for other things, but at very minimum with the APP, you'll develop a care plan that will likely include, like Dr. Manders said, an annual visit. Even if you're not getting the imaging done yet, you'll come in, you'll have a discussion, a physical exam, to continually evaluate your risk. And in the event that something is discovered, then maybe you'll get an early referral for imaging or discussion with Dr. Manders or someone else. So the beauty of the high-risk clinic is that once you become a patient, the goal is to never be lost to follow-up. Because once you're identified as at risk, there will be a plan set in place for you for whatever referrals or annual or semi-annual follow-up or imaging or whatever that is specific for each patient. Because
Burns, do you want to clarify real quick what an APP is?
I'm sorry, I apologize, an advanced
no, you're not
provider.
Sorry, go on.
So these would be nurse practitioners. I'm Canadian, we're sorry about everything.
No, you're sorry.
I'm sorry. Oh, geez, I'm sorry. Dr. Manders and I are both Canadians originally. So an advanced practice provider is what some people call a mid-level provider. It's a nurse practitioner, a physician's assistant, someone like that who works with a collaborating physician. So for example, the advanced practice providers currently in our high-risk cancer screening clinic actually work directly with the surgical oncologists as their collaborating physicians. So it's really someone to get you in the pathway, to follow you on an annual basis, who is well-informed to be able to provide referrals when necessary to specialists who can help further your care.
All right, great. Last question. Dr. And I'm not quite sure, I think it must be referring back to something you've said today. Dr. Manders, why would estrogen levels matter with the MRI?
Hey, great question. So your breast tissue is made up of glandular tissue where milk is made and how the milk travels to the ducts or to the nipple via ducts. And then it's also made up of stromal or supportive tissue. And many, many cells in your breasts have what are called estrogen and progesterone receptors, which are these tiny little proteins deep inside on the nuclear membrane. And when in the presence of estrogen, estrogen stimulates the growth. And so when you are premenopausal, your body's producing hormones on a cyclical basis. And sometimes of the month you are at higher levels of estrogen, and sometimes you're at higher levels of progesterone. And that's all based on this way that your brain and your pituitary gland and your ovaries talk to each other. And so, and what time of the month it is. And so the higher the estrogen level in your body, the more stimulation of your breast tissue, and the more likely you're going to see a lot of things pick up the gadolinium contrast on MRI. This is why hormone replacement therapy in the postmenopausal patient is a risk factor after several years for developing breast cancer, because you are unnaturally stimulating those cells that are expecting to go through the change that your body's gone through. And if you have atypical cells tend to have estrogen receptors. So your body's hormones are very much tied into your breast health. Great question.
Thank you very much. I really appreciate everybody who sent in their questions. If anybody is interested in scheduling a genetic counseling appointment, the number is here on the screen. It's area code 513-585-3275. And thank you again. Just a quick
plug. You can also schedule directly through MyChart if you so choose, or on our website.
Right. If you have a MyChart
free
account, get one.
Try out all the different ones.
Thanks, Burns. Thanks, Burns. I really do appreciate Burns, Bryanna, Dr. Manders. I really do appreciate all of you participating today. And I am very quickly going to hand this over to Beth Nolman, who is one of my colleagues here at the foundation, to make some closing remarks.
Thanks, Jenny. Fantastic job today. I know we're slightly over the 5 o'clock hour, so this will be real quick, but as mentioned, my name is Beth Nolman. I'm Director of Development here at the Christ Hospital Foundation. Before we conclude, we just wanted to say a few words about the importance of community support to make programs like the one you heard today possible. We are proud to be recognized as the region's most preferred hospital, thanks to our research, leading technology, skilled clinicians, and the extraordinary care that they provide. All of this has been supported by caring individuals who recognize the importance of having a first-rate hospital close to home that they can turn to when it matters most. Whether it's supporting initiatives like precision medicine, financial assistance to help our most vulnerable patients, or capital investments to support our continued growth, donor support is vital to our ability to do better. One new project that I think might be of interest to many of you on the call today is the hospital's plans to build a brand new comprehensive breast center here in Mount Auburn. The reimagined space will create a more personalized, serene environment to complement our existing work promoting patient-centered care. Today, I invite you to consider how you can support the Christ Hospital through your own charitable giving, both now and in the future. With support from friends like you, we can provide the best care for you and your loved ones. My colleagues, Heather Sherwood, Diane Fisk, and myself will be in touch following today's event to share more information about the many ways you might consider getting involved at the Christ Hospital. We appreciate your time and thank you for the great questions and thoughtful attention. I'll let Jenny, back to you, and I'll let you close things out. Thanks.
Thanks, Beth. Really appreciate it. Everyone who is attending today will receive a link following the event for a brief survey. Please send us your feedback. It's very welcome and it helps us improve and do better over time. Before I close, I want to again thank our speakers, Debbie Hayes, Dr. Burns Blacksall, Dr. Jennifer Manders, and Bryanna Rivers for participating and sharing their wealth of knowledge. And most importantly, I'd like to thank each of you for attending today. If you're a donor or volunteer of the hospital, thank you for your continued support. If you're a patient, we appreciate you choosing the Christ Hospital for your care. And on behalf of everyone here at Christ, we wish you and your families good health and have a wonderful evening. Thanks.
Thanks again.
Bye.
Bye.